Thank you. I would like to call upon the next speaker, Dr. Bhagwati, who will be talking on canalicular lacerations. This again a very common scenario we face, especially in multi-specialty hospitals.
Good afternoon, one and all. So after this ocular tumor session, I'll be talking with for trauma of canalicular lacerations. I'll be giving you a few tips. I'll be dealing with the indications of canalicular repair, when to repair and how to repair. So this lacrimal drainage system forms 16% of all eyelid injury, and it mostly affects the lower canaliculus in 50 to 75% of the cases. And like any other trauma, it is more common in the children and the young adults. So when we go for managing these cases, we have to take into account not only the functional aspects, but also the cosmetic aspects. So we can classify into direct injury and indirect injury. Direct injury is caused by penetrating in sharp objects such as a knife or the spokes of bicycle or the cloth hangers, and the blouse hook injury is more common in the breastfed infants. The indirect injury is by the contusion from the punch or fall or road traffic accidents. So sometimes the injury is so occult, like this case, the 6-year-old boy, this 10-year-old girl, they had injury while playing with the fence and the spoke of the bicycle, and when you don't do probing in such cases, you are going to miss these cases, and this will heal with scarring and will lead to the epiphora. The indirect injury is usually on the lateral part away from the canaliculus, and this will stretch the lid beyond the point of the avulsion, and this will cause a tear in the canaliculus because this part lacks the tarsal plate and it is very weak. Usually the indirect injury, they are distal canalicular, they have a distal canalicular cut. Distal canalicular cut means near to the sac. The cut is near to the sac. The proximal, whereas the direct injuries are mostly the proximal injuries. This cut is towards the punctum. Now this is important to know because the distal canalicular cut injuries are more difficult to manage in terms of identification of the cut end, which is towards the sac. Now the medical management is like any other trauma, that is ensure the tetanus vaccination, anti-rabies vaccination in case of dog injuries, even antibiotic cover in case of the contaminated wounds. Now in all canalicular injuries, we have to repair with the stent so as the anatomy is restored and the eyelid physiology and the pump mechanism returns back to normal. So in all both canalicular injuries, we should do stenting. Even in the single lacerated canaliculus, there is 10% risk of epiphora. And when we repair with the stenting, it not only removes the risk of epiphora, but it also gives the good eyelid position post-operatively. So timing of intervention is no longer guided by the immediate surgical intervention or the historical recommendations of the 6 hours. And most of these cases are from the road traffic accidents. They have the associated injuries, so they cannot be taken immediately. So repair can be done within 48 to 72 hours. Even in the literature, the successful repair has been reported 5 to 7 days after the injury. So these are the different options. This one is a monocanalicular stent, and from the Orolab and the FCI, I have no financial disclosures to make. And this is a bicanalicular stents. More common is the Crawfords and the Rettlings. This is a pigtail probe. So traditionally, the pigtail probe and bicanalicular intubation was used for these canalicular lacerations, but these needs more expertise. And when you you have to pass through the normal canaliculus, so there's a risk of damaging the normal canaliculus. Now these more simpler ones are available. These you can use even for 2-cut canaliculus. You can use the individual monocanalicular stents, and these are more simpler and doesn't need much of the expertise. There's no risk of damaging the another canaliculus. Now the first step to the canalicular stenting is to identify the cut end. So this is a proximal cut end. So this is very easy to identify. You have to just pass the probe through the punctum, and you can see it coming out through this cut. So this one is a distal cut end, which is more difficult to identify. So this is more difficult to identify. Once you have the cut, this is further retracted towards the orbit, and then it is difficult to identify this cut end. So the first key step for identification of the cut end is to use the magnification. You can use either microscope or you can use the loop. I usually use the microscope and inject the very little amount of the anesthetic. And third tip is to you do the blunt exploration and keep your sharp tooth forceps only for retracting the skin. So the most important step is to, like in the literature, the different, they have given different options, like the people inject the ear from the normal canaliculus, or they can inject the fluorescent stained dyes, but these has never worked in my hands. When I inject the dye from here actually, so it usually leaves through the nasolacrimal duct because there is always edema of this part. So this has been never very successful in my hand. I usually identify it from the appearance or clinically. So where you have to look, that is more important. So you have to look below and behind the caruncle. So most of the time you will be able to see this pearly white opening of the canaliculus in the pink tissue of the orbicularis. And once you feel it, it is very elastic and very thick walls. And once you see it, you are not going to forget this. Now, this is a monocanalicular stent which we use. So it is having a body which is 40 millimeter in the length, and this one is a head. So there is a bulb which will go into the ampulla of the canaliculus, and this is a collarate which will stay outside the punctum. So this is a small clip, so we have to dilate the punctum first, and then you have to pass the tip of this monocanalicular stent. You have to be perpendicular to the punctum and pass bit by bit. So once you see it exiting through the other end, then just pull it out, and then you push the bulb inside, and the collarate will remain outside. You have already identified the distal cut end, so you push it through the distal cut end. When you are in right place, it passes very smoothly. Okay, once it passes, the next step is to put the sutures. So when your cut end is towards the punctum, it is very easy to suture. That is, you have to suture it like any other marginal lid tear. But when it is towards the sac, then you have to keep in mind that you have to direct this vector of the medial canthal tendon towards the posterior lacrimal crest. So you have to pass the two double-armed suture with the cutting needle through this end, and while passing through this medial cut end, you have to swipe through the periosteum and then come out through the skin at this medial canthus and tight over the bolster. So this is a post-op picture. You can see this collarate outside the punctum, and you can keep it for 1.5, 6 weeks to 3 months, and then you can remove it under the magnification of the slit lamp or the loop. You have to just pull this collarate with the tooth forceps and pull it out. Okay, so take-home message is always suspect canalicular tear in the medial eyelid injury. Whenever possible, do canalicular tear repairs with intubation. Always and always use magnification. Thank you very much.
Thank you, Dr. Bhagwati. Actually, you made a point that you never succeeded in identifying the distal part of the canaliculus by using stain, right? But our experience is different. See, especially when they come late.
Maybe.
You won't be, I mean, it's very difficult. That the most difficult part of canalicular tear suturing, identifying the distal part. So we have used the fluorescent dye or the trypanlo, it works. So you pass through with little.
Maybe that by that time, if you're seeing late, the edema is not there. But I have always seen actually
with little force, it's most of the times it comes, but it's a big help for us.
Okay.
That's what I've observed.
Okay.
Anyone from the audience can add.
Yeah, do a blunt dissection.
But will it be there even after few days of injury? I mean, or at least correct. Especially, I'll get a call from my junior colleague. Ma'am, I'm not able to identify, then I tell this. Because I'm not there to tell her like how to identify, then I tell. Most of the times they do it.
Actually, it is too much retracted inside, and it's really difficult to see whether the saline is coming out.
Until the edema subsides, and then I do the surgery.
Okay, fine. Thank you.
blanching, it's okay. That
Because these patients, they don't want to wait because their tear they see,
Correct,
so
correct.
they want to get it immediately
Correct.
done.
Plus, in the same, see, they will have other injuries also.
Yes.
So in the same OT, I think the sessions we have to finish everything
Yeah.
at the same GA or whatever.
So that position, if you just go there below the caruncle, I have usually found every time.
So this,
That is my experience. Yeah, it will be there.
so there's
Just
there's
below
another
again.
simpler way. I have used this most of the time. So if there's no bicanalicular injury, you can just inject diluted betadine from the other canaliculus,
Diluted?
betadine or whatever you want to use from the other canaliculus, and just you can easily identify.
If it
the
is a proximal towards the punctum, you can identify it easily. But if it is towards the sac, it's hard to find.
So the cases that most of that the
Proximal
cases,
one is easy,
Yeah,
you can
maybe.
identify.
I agree.
usually.
So the cases that we get in our practice are usually not these clean cut cases. They are crush injuries.
Yeah,
In crush injuries, however hard you may
That's
try,
what I was trying to tell.
you cannot
That's-
tell the punctal pout. There's
Mm.
sometimes you just can't. So then it
Yeah,
becomes a very difficult proposition, because as an oculoplastic surgeon, you feel that I should take care of epiphora as well as cosmesis, and it becomes very difficult sometimes. It's not that easy. It's not that easy. Yeah.
I will be digging and you'll be causing more and more injuries.
Beyond the punctum or a linear tear, when it is a horizontal cut, the pale pink invariably it will be there.
Challenging ones.
For
Those sharp injuries, I think they're easier than the blunt.
direct
crush
injuries are usually the towards the proximal punctum. It will be by sharp. That is easy to
Easier.
identify.
These are more of blunt crush injuries.
Towards the sac is very difficult to identify actually.
Ma'am, hi. It's a very basic question. How long do you keep the length of the mini monoca? You put the entire length or you cut
Entire. If you are in right
Invariably
place,
you need
the
to,
entire thing will
like,
go.
trim
it?
it.
You push the entire length?
If you are in right passage, the entire thing
pass
passes
right
inside.